Looks like I'm going to bring this one home. So, um, thanks for listening again. I wanted to. This is the other topic I wanted to kind of talk about. It's a variation on a theme. Again, if I didn't introduce myself to those, I'm Bobby Welch. I'm at UT Southwestern in Dallas. So, and I'm a neurosurgeon and an endovascular person. So, um, same as before. When we're treating the basilar, in the age of bifurcation devices and things like that, obviously stenting seems passe. But I think, with the availability and the economics of endovascular, it's always good to have options in terms of how we're treating bifurcations. At the basilar, there's a wide neck basilar with coil retention, with as I mentioned, the economics, the recurrence, if you don't have any good neck coverage. There's a lot of there's multiple stent configurations that are possible, but maybe not the most economical. About 2009, we wrote, this was in JNIS, talking about retrograde basilar stent placements, or horizontal stent placement, but retrograde. The good part about that is you have a horizontal and diagonal. So horizontal is P1 to P1, diagonal is P1 to SCA. And in this, we really found that the orientation of the recipient vessels was important. And we didn't see any complication from vasospasm or animal hyperplasia. So this is a well-documented method. But we use neuroforms here at the time just because of the open cell design and the ability to cross. The downsides to this approach, though, are the fact that you've got two circulations that you're actually going through. So there's been a multitude of Y stents and gamma stents and waffle cone and all these other types of things. Kind of looking at a transbasilar, so single circulation placement of a stent to take care of and work with wide neck basilars, with the real goal of a single circulation, less device, less recurrence. I think patency of the PCA is obviously at the end of your treatment, but also lower cost. And as we mentioned in the prior publication, the angle is really important. And so this is just kind of an illustration of how I think about the angles. This is 180 degrees working from 0 to 60, and this will come up a bit as we get into the other discussion. So the horizontal stent placement from the antigrade standpoint really looks at placing a catheter into one or the other of the PCAs, and determining factors for me really are the smaller PCA and the presence of a PCOM. If both of them are the same size, but there's a PCOM on one side and no PCOM on the other, I'll choose the PCOM side. If there's a smaller one with the PCOM there that's really serving the circulation anyway, I may choose that side. But the ability, what you really want is more this. This is not optimal, right? Because you're really not helping. This is very akin to that waffle cone that I think was published out of Buffalo not too long, or years ago, that really didn't kind of hold on, because you're not really protecting both PCAs. You got a way of getting into this PCA with the coils. So what I'm wanting to just kind of show here is kind of my work with just an antigrade horizontal basilar stent placement. And typically what that means is, you can see here is an example case for the stent. And I tend to use the Neuroform still, the EZs, and I'll talk about the other more recent stents like Atlas and Elvis. But it's a little bit more rigid, and you need that rigidity. The Enterprise stent, because of the flares, really, if the Enterprise stent, because it flares, if you really get that flare here, it really gives you no coverage. So the ability to place that, you can pass through it very easily, but it gives you no coverage for the neck. And I found that the Elvis and the Atlas stents, when I've gone up there to do a similar technique, they almost bend too much. They don't allow for coverage across the neck. What you'll end up doing is an angle here or a bowing up into here, but it really doesn't give you the coverage of the other PCA, which is why I've tended to, even though it seems, I think, older technology, the EZ has really worked pretty well for me. 017 catheter, as we all know. And again, the PCA choice is really based on the size and the presence of the PCOM. This stent bump is really something that is very well tolerated. Once the stent is about 2/3 out into the vessel, I'll deploy the stent and try to do my best to give it a little bit of an angle, but leave it this way. If it's just a little bit down, moving it, just bumping it with the catheter, actually, it will kind of come right into place and give you that coverage across that neck. And that's really what the stent bump, and what you'll end up with is something very similar to what you would see with any other horizontal stent, but you don't have the anterior circulation coming into play. So this would be the AP view and the lateral view. And as we all know, for horizontal stents, we want to see that nice little curve, which shows that the coils are respecting the stent and staying in the aneurysm. So this is an example case of that. So I asked our fellows, Dr. Abbas Vance is one of my fellows. We kind of looked and went back to 10 different cases over, I think this was about from 2012 to 2018. These are the ones that I did that I thought were appropriate. All of them obviously were basilar apex cases, except for one right superior cerebellar that was quite large. And that's the one time that you ended up with more of that diagonal component to it. But you can see the sizes there, all decent sized aneurysms. The dome to neck ratios were as detailed here, and all of them were Neuroform EZ stents. A couple here were 2 Neuroforms. That's just really what was based on size. At the end of the day, we ended up with, there's only one that had any kind of, recanalization that we classified as a 3, but everything else kind of stuck between 1s and 2s and remained stable. And all of these are 1-year results. So that's why I went back to 18. Again, we didn't have any in-stent stenosis. So where we chose to place the vessel, the catheter, it went well. I did have a patient with some spasm in the PCA. Once that went out, that relieved very well with some nitro. Most of the stents I kind of chose in that 15 to 20 millimeter range. So that, and all of them were about 315 to 320 on the Neuroform. But again, the distal 2/3 out into the vessel, and really the best angles were if we were measuring angle between about 60 and 140 was about the best angle to still get good coverage of the PCA. Because remember, that's the whole point, to kind of reconstruct that horizontal type coverage. If it was anything in that 140 to 180 or anything from 0 to 60, it would just flop and wouldn't give us good coverage of the contralateral PCA. So, I think I think in those 10 patients, you could see it safely achieved the goals of, a single stent and good durable treatment. Lower number of devices, obviously. This is an older stent that's I think very available to most places throughout the world. But it really needs to cross that entire aneurysm. And remember, the flared ends and the more more closed-celled Atlas, Elvis, newer stents almost are too malleable. They move too much. And as we remember, we had some of these cases. I think most of the Enterprise cases that did the retrograde migration were basilar cases also. So I think it had something to do with that flare. I think one of the things that I'm worried about when I'm doing that, if you have the tines, as we saw back into this prior case, if you can see those tines out, chances of tangling a coil or getting a coil wrapped as you're coming back and forth, you don't do as much dancing. I tend to dance a lot when I'm coming in and out of the aneurysm. I don't do that as much here. And so that's something to kind of pay attention to. But there was never a case of that, in the cases we've done so far. So I put these references up here. This has been submitted and accepted recently, but these are just kind of all of the different configurations that I was able to kind of find in terms of, P1 to P1 horizontal stent placement using, an alternative to the Y technique. This was still through the PCOM. This was horizontal. This was also through the PCOM. This was this alpha stent, which was kind of angled up but through the basilar. But and this is your waffle cone look again, which I think has kind of died off. So I think in general, this has worked well for me. And then the patients that meet that degree range, I think it's helpful, and it minimizes. I don't change any of my antiplatelet use. It's basically 6 weeks that we keep it on. So I just wanted to kind of throw this up here as another alternative. And I'm always interested to see if other people are doing other things. But to me, less is more when it comes to devices. And I think this satisfied that goal. So do you know where that is? So,
do you think it's better the open cell or the closed?
I think the open cell, like the Neuroform, is an open cell. You can cross it better. And I think that's what gives you a little bit more of that kind of rigidity in terms of being able to flop things up. So that's why I kind of went back to the Neuroform EZ. So, yeah.
You call it horizontal stenting, but it's kind of half T stenting, which done with Korean colleague. They described the enterprise stent in bifurcation aneurysm. It's incomplete T stenting. It's just one stent, and
Right.
also Elvis Jr. and Leo, mostly Leo Baby used for such kind of configuration. And usually in our practice, we place this stent, coil assist stenting. We
Mhm.
place coils, then stent.
And stent below it.
Yes, and Rene call it half T stenting.
Do you leave that? Do you leave the stent? But you leave the stent in the basilar and then turn the corner, and that's where the horizontal. It's not quite P1 to P1, but the whole goal there is to kind of have it going all the way across and not left in the basilar. So
Nice technique.
yeah.
What you describe here actually it's an N clip, right? Instead of E clip, you're
Yeah.
using neuroform, but exactly the same technique
Yeah.
to cover the neck of the aneurysm and then do the treatment, right?
Yeah, pretty much. Yeah, you just don't have the you. I think it's probably cheaper, but yeah, I think. Well, I don't know. I guess Joe's left, right? So I don't know how much the E-clips are, but again, the whole idea there is using something that we already have, and technically I haven't found it to be that difficult to do that, and just a little bit of a push and it'll cross right across. So, but yeah, in clip. So, yeah. So this is Santiago del Mar, which is up in northern Spain. If no one's been there, it's gorgeous, and it's right up in northern Spain, not too far from Altamira, which is where the caves are, where the prehistoric caves are. It's a little medieval town. This is one of the cathedrals out there that I went to one time. So there's your Spanish reference. So thank you.